All right, well, it's hard to be last, but here we are, last lecture, and it's been a great day, hasn't it been? I tried to think about a way that I could beat Jonathan's introduction where we all had to make faces, and instead we're just feeding you vulva cupcakes, so just imagine what it's like from my end to be watching you all. We'll leave it there. We'll leave it there. All righty. Thank you, Jason, for the introduction. Thank you, Rajam, for inviting me to come and speak. I'm a clinician. I'm a pelvic floor advocate. If you've ever spoken to me, I like to speak about the pelvic floor ad nauseum sometimes. And it's like, okay, enough now. I'm an educator, and I've started to become a researcher because I believe very much that as a clinician, we need to start to assess more critically if what we do is actually working. And last but not least, I'm a Canadian. So I'm gonna talk a lot about physiotherapy instead of physical therapy. It means the same thing, it's just Canadianese for that, okay? Jonathan already beat me as well to the Star Wars analogy and threw up Yoda on the screen, so it's hard to follow that act, I tell you. But I do actually want to recognize that Yoda was the legendary Jedi Master, and it was considered that he had the most connection with the Force. And so in honor of Yoda, I actually want our pelvic floor therapists who actually treat the pelvic floor consistently with all their patients. That doesn't mean you do it internally, but therapists who really have connected with, hey, the pelvic floor is important. Can you just stand up for a moment? How many do we have here? Awesome, please stand. I'm so happy to see some guys up here, awesome. Okay, so these are our Jedi Masters in the room right now, and afterwards, if you have questions about integrating pelvic floor therapy into your practice, please talk to one of these folks, it's great. The aim of my talk really is so that everyone in this room starts to recognize the importance of integrating pelvic floor rehabilitation into every single patient. It doesn't mean that we need to go internally, but it means that we need to recognize the importance of the pelvic floor in all of our patients. So that's really one of the things that I want to talk about, because I think especially in low back pain and pelvic pain, we treat in silos. I'm the gynecologist, I see the visceral stuff. I'm the orthopedic therapist, I deal with pelvic girdle pain and low back pain. I'm the pelvic floor therapist, I do the internal stuff. And instead of treating the person in front of us, and we've heard that all week about how important that is, we tend to treat in silos. So I think one of the things that we tried to do with some of this initial research that we've done is to say we've got to stop doing that, even from a biological perspective, out of that sort of biopsychosocial. So to start this talk, and I actually just talked to Melissa about, I was just confirming that this is where I got this slide from, and indeed it was. Melissa presented this slide, I think, at the 2013 Abdominal-Pelvic Pain Conference. And I just wanted to start with this slide because I love how she put that really everything that happens in the pelvic floor is the basis of human need, right? If our pelvic floor is not functioning well, our basic physiological needs, according to Maslow's hierarchy of needs, are not being met. And not only do we need to have good sexual function, bladder function, bowel function, all of those pieces, musculoskeletal function in the pelvic floor, it needs to be yes-receptive, not nociceptive. In other words, if you have a good bowel movement, it should feel good, right? You should get off the toilet and go, wow, that was great, right? And I know all the guys in the room know exactly what I'm talking about, right? All right, so one of the things, though, that we recognize is that pelvic floor is a set of, the pelvic floor muscles is a set of orphan muscles. I think they're largely ignored by most medical professionals at this point. They're often overlooked in our rehabilitation programs. We are embarrassed to talk about them. Our patients are embarrassed to talk about pelvic floor problems. And so we don't ask the questions and they don't bring it up. And so it becomes the white elephant in the room, right? A lot of therapists and a lot of clinicians don't recognize still, even now, that pelvic floor dysfunction is not necessarily a problem of weakness, but it can be a significant problem of tightness. And in fact, what we know about pelvic floor dysfunction is that the pelvic floor muscles are highly affected by stress and tension. And we can kind of see this from a couple of different physiological reasons or even psychosocial reasons. And the first was actually demonstrated by Van der Velde in 2001, where she showed women very frightening pictures and very frightening film actually, and put EMG sensors over their body to see which muscles actually contracted first. And before we move away, blink, or do anything sort of protective, the very first muscle to contract are pubovaginalis muscles, or our pelvic floor muscles, right? Kind of makes sense. When you think about it from a procreation perspective, when you think about it from a survival of the species and moving forward as far as just bringing our race forward, we are hardwired to protect our pelvic floor muscles. When you also think about the nerve supply for the pelvic floor, one of the things that we know is that the pudendal nerve is the only peripheral nerve in the body that has motor, sensory, and autonomic functions, okay, fibers. And so that's really important because, again, we don't want to pee when we orgasm, and we don't orgasm when we pee. And when we jump up and down, we don't want to do either of those things. It's not really cool, okay? And so we need this coordination in the pelvic floor. And so our pudendal nerve takes care of that. But what also happens is when we're in chronic fight-flight, right, the sympathetic nervous system is wound up. So do our pelvic floor muscles, and so do our organs get wound up, right? Ray, you're trying, sorry. Well, Ray's jumping in the back. We won't ask why. Okay. Okay, the other physiological basis behind tension in the pelvic floor is that we know the respiratory diaphragm and the pelvic floor diaphragm are supposed to work as a piston, right? So that when we breathe in, our abdominal wall relaxes and our pelvic floor eccentrically lengthens as our respiratory diaphragm comes down, and the converse happens when we breathe out. So we can imagine, again, with our patients who are in a chronic fight-flight sort of situation and they're apical breathing, we're not getting that nice excursion in the pelvic floor diaphragm, and so we tend to get a short, tight pelvic floor, okay? So our research question really was, is the low back always the problem in low back pain? And this was really informed by empirical research that's been developing over the last 10 years. Eliason in 2008 did a study looking at 200 women with low back pain, and 78% of them had pelvic floor dysfunction. If we look at Michelle Smith's study, which was done along with Paul Hodges, we all know who that is, in 2006, they did this beautiful 5-year longitudinal study looking at 38,050 women. I mean, that's a researcher's dream, especially in physiotherapy. That's a huge sample size, right? And one of the things that we used to say up until that point, because I've been doing physiotherapy for a long time, is that some of the strongest comorbid factors of low back pain were weight loss and inactivity. So, you know, sort of standard fare for women going to see their family doctor would get active and lose weight, and your back will feel better. In fact, what this research study showed is that the two strongest comorbid factors of low back pain were actually pelvic floor dysfunction and respiratory dysfunction. Again, the top and bottom of that canister, that piston, right? Van Wingerden, so JP Van Wingerden did a nice study and actually presented it at the Amsterdam First Abdominal-Pelvic Pain Conference in 2013. It was a poster presentation. As far as I know, this has not been published at this point. And he works as part of Joe Nish's group. Again, it was a big study. They did 1,636 patients, and they looked at the presence of pelvic floor dysfunction in pelvic girdle pain and low back pain in both men and women. So we actually used their study protocol as far as identifying pelvic girdle pain and low back pain in our study as well, that I'm going to talk to you about in a moment. But what they showed is that 2/3 of women with pelvic girdle pain had pelvic floor dysfunction, and about 60% of women who had combined low back pain and pelvic girdle pain had pelvic floor dysfunction. And about 1/3 of men, right? So this is not just a female problem. Now in our study, we just looked at women at this point, so we're not going to talk too much further about men, but this was sort of the basis of why we decided to look at this further. Now, in all of these studies that I'm talking about here, they measured pelvic floor dysfunction by giving patients a screening questionnaire. Do you have urinary continence? Do you have fecal incontinence? Do you have pain with intercourse? Do you have pelvic organ prolapse? But to this point, no one has actually done an internal exam on these women to see what their pelvic floors actually were doing and what they looked like. So that's what we've decided to do in our study. So this is a study that Dr. Sinead Dufour, who's a researcher who also has become a pelvic floor therapist over the last 3 or 4 years, and myself completed through McMaster University. It's submitted for publication at this point. It took us about 2 years to complete. It was a study of love because we got no funding to do it. We did it completely on volunteer basis with our clinical researchers. The purpose of this study was to build on that current literature base that I was just talking about to determine the prevalence of pelvic floor dysfunction in women who were referred to an orthopedic practice for low back pain. That's what we were looking at. And then we wanted to quantify that pelvic floor dysfunction. Okay? It was a prospective cross-sectional study. So again, we just have to remember we are looking at correlation. We're not looking at causation with this study design. The inclusion criteria were females who were being referred to an orthopedic practice for low back pain, not pelvic floor dysfunction. So if a woman was referred with low back pain and urinary incontinence, she was excluded from this study. Okay? They had to be greater than 18 years of age because we were doing an internal exam. English could not be, they needed to be able to read and write English. And we excluded more complicated low back pain. So we excluded women who came in with radiculopathy or an inflamed nerve root. We also excluded women who had high levels of catastrophization. Wasn't Beth Darnell's talk yesterday amazing? It was really great. I've been using the PCS questionnaire in my practice for at least 5 years, and one of the reasons that we decided to use a cutoff of greater than 30, which actually represents, if anybody knows the PCS scale, that actually represents a severe level of disability. Okay? So these are extreme catastrophizers that we excluded from the study. And the reason we didn't go to a cutoff of 20, which is actually moderate catastrophization, is because in my clinical experience, almost all of my patients have at least a score of 20. We'd still be recruiting women for this study, and it took us 1.5 years, okay? So that's why we had quite a high cutoff, and we'll talk about that in a little bit more detail in a moment. We're also looking for, or excluding women who were currently using narcotics. So we just tried to exclude the more complicated sort of set of low back pain. The actual study design, we used 7 clinical orthopedic sites. We did a day of on-site training where everyone got together and we made sure that all the tests that we were doing could be standardized and reproduced by each other. There were 8 clinicians who worked out of those 7 clinical sites. There was a total of 182 women invited to participate in the study, and we ended up with 100 women in the study. 82 were excluded for the variety of reasons that you see in front of you there, okay? Our highest reason for exclusion was catastrophization, and our second highest reason for exclusion was refusal to do an internal exam, and we'll talk about a little bit about both of those in a few minutes. The actual methodology that we used, again, remember I said it was based on a similar study protocol that J.P. Van Wingerden used in their study. It's also based very similarly on study work that Annelies Gutka has done as well in looking at determining pelvic girdle pain and low back pain subgroups. So when a patient came into the clinic and they agreed to be in the study, they had a full mechanical assessment done. So we did repeated end range test movements, basically a McKenzie assessment. We looked for centralization and peripheralization of their symptoms, and we looked for worsening and improvement of their symptoms. And if that happened, then we put them in the subgroup of mechanical low back pain. As I fall over. Okay, let's do that again. All right. Pelvic girdle pain, we specifically, and again, I know there's been a lot of research that's come out recently about the active straight leg raise test and what are we measuring. Again, we use this protocol similarly to what has been published in the past. So if they had a positive active straight leg raise test looking for heaviness using that same scale of grading heaviness from 0 to 5, we added the left and right leg up together, and if they scored greater than 3 out of 10 in total, it was a positive active straight leg raise test. They also got a positive if with compression their straight leg raise test improved. They got a positive tick if they had a positive forced Faber's test, and they had a positive tick in that column if they had a positive P4 thigh thrust test, okay, which is a provocative test for pelvic girdle pain. In order to meet the criteria for pelvic girdle dysfunction, or pelvic girdle pain actually is the word I should use, they had to have 3 out of those 4 tests positive. Then there was also another subgroup that they could be categorized into where they had both low back pain, mechanical low back pain, and pelvic girdle pain. And then they had a pelvic floor assessment done, and the pelvic floor assessment included firm palpation for tenderness in the vagina. Strength assessment, we used a modified Oxford scale that has been validated by Helena Frawley in her work. And we looked for the presence of prolapse, both vaginally and rectally. The patient also completed self-report measures, including the Oswestry Low Back Questionnaire, and they reported themselves on 5 specific areas of pelvic floor dysfunction, including those areas that you see listed there. I don't need to read them off. Dyspareunia, for those of you that are not familiar with that term, means pain with intercourse. Okay? So 100 women came through and did that full assessment. The mean age of the women in our study were 41.6 years of age. And what was interesting is that we saw a very strong correlation with women who were referred for low back pain with pelvic floor dysfunction, okay, 96%, all right? 84% of the participants had tenderness on palpation. And we'll talk a little bit about tenderness on palpation, but essentially right now clinically that is seen as the assessment tool that we use to determine if there's overactivity in the pelvic floor muscles. So think about someone who has overactive lumbar extensors or overactive trapezius muscles. Really the only way we can tell that clinically is tenderness on palpation and you're feeling for the quality of the muscle. So we're doing the same thing internally. It's not a perfect objective test at this point, and we'll talk about that in a few moments. We really do need some research to be done to validate a more objective measure of overactivity of muscles, okay? So 84% were actually overactive, 67, or about 2/3, were found to have pelvic floor weakness, and about 1/3 of women demonstrated a prolapse. So the assumption often in orthopedic practice continues to be that these pelvic floors for low back pain patients are weak and they need core strengthening, right? And in effect, what we're seeing is that there is an over-recruitment, which fits in with the tensioning pattern of low back pain that Peter O'Sullivan has been talking about for the last 3 or 4 days, right? It kind of fits with what we see at this point. Just a little group there, we did not exclude pregnant women, so we did have 13 pregnant women in the study. That sample size isn't really big enough for us to make a lot of strong conclusions on at this point, but what we did notice is that their dysfunction was very similar to non-pregnant women, but that there was a higher correlation to pelvic girdle pain, which again makes sense with what we would expect to see. Once we started to look at the data a little bit more specifically, one of the things that we saw was that there was a 100% correlation between self-report of pelvic floor dysfunction and the patient self-report and objective examination, okay? So if you have a patient who's reporting urinary incontinence, fecal incontinence, prolapse, dyspareunia, pain with intercourse, and chronic constipation, there was a 100% correlation with finding problems on the pelvic floor exam. There was also a very strong odds ratio. So if you don't know a lot about the odds ratio data, any odds ratio greater than 1 is seen as clinically significant at this point, okay? So there was a significant correlation between pelvic floor tenderness and painful intercourse. And I think logically that makes sense. There was also a very high correlation with pelvic floor tenderness and reported perineal or genital pain. So if a woman complains of pain in the suprapubic area, in the vagina, in the anus, in the perineal area, in the inner thigh and groin, then that was highly correlated with an overactive or a tender pelvic floor, okay? Women who also had a tender pelvic floor had a much higher likelihood of being disabled than women who had a weak pelvic floor. So we saw that correlation as well. So when we look specifically at pelvic floor tenderness, we look at other research that has correlated this finding. And Cynthia Neville and her group in Chicago in 2012 actually did a study looking at 60 women. 30 women had chronic pelvic pain and 30 women did not have any pain. And so what they did was they tried to determine which musculoskeletal tests would best determine women who had chronic pelvic pain. And so they had 9 tests that they were looking at. They did a double-blind study, so they were looking at identifying women without knowing who had chronic pelvic pain and who did not. And what they found from those 9 tests, that there were 2 tests that stood out, and they had 100% correlation for specifically being able to identify women with chronic pelvic pain. And those 2 tests were a positive force Faber and the presence of pelvic floor tenderness, those 2 things together. So in our study, actually, we verified those results, and 90% of women in the combined pain group, so mechanical low back pain and pelvic girdle pain, and 100% of the women in the pelvic girdle pain group only had a positive force Faber and pelvic floor tenderness. Okay, so putting those 2 together is very predictive of chronic pelvic pain. And what was interesting is we did not see that same correlation with mechanical low back pain. All right, so we have some weaknesses in our study, and certainly things that we learned as we went along the way, and looking back would have changed some things we didn't have the opportunity to change, of course, or wouldn't even at this point. One of the things that we need to recognize is the subjective measure of tenderness or tension is not a really great objective measure, all right? And if you're looking at 8 clinicians over the course of the study, there is definitely room for variability in that interpretation, okay? Second study weakness is that because the study was done with one therapist only, there was no way to blind that therapist when they did their objective exam and the patient reported their pelvic floor dysfunction. They then were also the therapist to do the internal exam. Okay, so there's some confirmation bias potentially going on there. And again, we also have to question, was it a heterogeneous sample? Okay, was there consistency across the 7 sites? So we did what we could to ensure that, but that is always a potential for bias. So what did the excluded participants tell us? Because I think there's more data here that we can get some more information. So what's interesting is that the highest rate of exclusion was catastrophization, all right? And even though we picked a really high cutoff mark, 41% of women were excluded because they had severe catastrophization. So one of the things that I really want you to think about as a take-home message is we need to be measuring catastrophization with all our low back pain patients, okay? And we probably need to set the bar a little bit lower than what we set in the study, okay? So there's definitely a high connection between catastrophization and lumbopelvic pain and taking a biopsychosocial perspective, okay? The other thing that we need to look at with lumbopelvic pain, we talked about these silos that we're in, but that we also, I think, as clinicians need to recognize the other pelvic pain conditions that are highly comorbid with chronic pelvic pain. And those are conditions like primary dysmenorrhea. If you have a teenage gal in front of you, how much do you ask her about her menses, her cycle, and what's happening with that? And does she take a day off a month to stay home from school because she's got a painful periods? Okay. What about women with interstitial cystitis? Do we even know what that is? If you're not practicing in the area of pelvic health, do you understand what that condition means, okay, and how that affects women? Endometriosis, 10% of all women have endometriosis. Do we ask that question? And so when we start to see those other conditions, we know that in lumbopelvic pain that they are very interrelated and comorbid, but also dominated then by central pain mechanisms, okay? And again, this is something that we need to be concerned about. We've looked at some cost data over the last 3 or 4 days as well, and I think that a lot of this data is probably shared data to some extent. I'm not sure that women, or where they get this data, that it may be reported on the low back data and on the pelvic pain data. But if you look at where pelvic pain starts to become a problem, it starts to become a problem with teenage girls. Okay, and if you look at the Australian data, which I have on the top right, the Australian government did a white paper, a position paper on chronic pelvic pain and published it in 2011. And they called the paper the $6 billion woman and the $800 million girl, because that is the cost of pelvic pain in Australia every single year. Okay, the Canadian statistics are on there. Unfortunately, I don't have American statistics for you, but I would imagine, based on the size of your country, that they're much more significant than that. I think there's another result that we need to pull out from the excluded participants, and that the second highest rate for exclusion was actually refusal to participate in an internal exam. So once they said, I don't want an internal exam, they were excluded from the study. And what was really interesting is that two of our highest study-producing clinics actually had similar experience in pelvic floor rehabilitation. So two of those clinicians had over 17 years of experience. And when we really looked at the data, one clinic had a 7.4% refusal rate, and the other clinic had over a 45% refusal rate. And so when we looked at that, we really tried to kind of figure out why that would have been. And the clinic that had a 7.4% refusal rate, that clinician was an owner of that clinic. It was a fairly small clinic, but her male partner who owned the clinic with her was an orthopedic therapist. And for the past 2 decades, they've been working in this model that we're talking about today. Every low back pain patient gets screened at the front desk and gets offered pelvic floor physiotherapy, or gets partnered with MJ, the pelvic floor therapist, so that low back pain can be addressed both from a low back and a pelvic floor perspective right from the beginning. Their receptionists are very good at asking the questions and screening the patients, and they're very comfortable. Right? So when we're comfortable, our patients are comfortable. And I think that's a message I want you to just think about a little bit, okay? The other clinician, she works very much in isolation within her clinic, a large, busy orthopedic practice, a fair number of orthopedic clinicians, but she doesn't work in an integrated model. She works very much as a sole sort of pelvic health therapist within that model. She had a new front desk staff at the time that the study started who was not comfortable screening and asking those questions at the front desk, and so we saw a high refusal rate in that clinic. Okay, so I want you to just think about that. What does that mean about your own comfort level and approaching your patients about some of these problems? All right, so one of the things I want to just sort of conclude at this point about the study is that it really acknowledges the interplay between lumbopelvic structures, including the pelvic floor, when treating women with low back pain, okay? We need to think about the state of the pelvic floor muscles. They're not just weak. This is an area of a lot of tension for women and men, for that matter, and that we really need to consider screening these muscles better, and we need a tool perhaps to do that. We need to also consider, given the high level of central pain mechanisms dominating many of these conditions, we need to consider a biopsychosocial framework for all of our patients. And now I think I'm preaching to the choir for all of you, right? All right, where are we going with this? Well, the next step, and I don't know if you got the handout. Did you guys get a screening questionnaire? They're somewhere. I never thought to check that while I was waiting to talk. Okay. No? No one has them? Okay. And they're not at the back desk? There's supposed to be a 1-page screening questionnaire that was supposed to be handed out. Okay. And otherwise, it'll be emailed to you. I mean, it's not a big deal that we have it physically in front of us at this point. But one of the things that I know that orthopedic therapists find very challenging is to start to ask these questions. And so one of the things that we do when we teach non-internal courses to orthopedic physiotherapists is we've created a tool to get them to ask things like how many times you void in a day, and whether you have pain with intercourse, and whether you have vaginal pain, and it's a screening tool for men and women, so whether you have penile and testicular pain. So all those questions that we don't standardly include in our assessments. We are now in the process of validating that questionnaire. So we took that original questionnaire we've been using for a while and simplified it to about 6 or 7 questions, and we're in the process now of validating that questionnaire. We also want to repeat the study with a male cohort, and we also want to repeat the study with hip pain in men and women. And we also want to start working with a large lab that looks at pelvic floor function to see if we can start working on creating a more first of all, a better definition of what an overactive pelvic floor actually is, and a better way of objectively measuring that. So that's a weakness internationally at this point. There's really no one that's doing that well. So how do we need to change our practice? Okay, we need to integrate some of these concepts into our practice, but really I want you to think about it as an evolutionary process. It's not something that has to revolutionize your practice. I think many of the things that you're doing, you're probably doing well at this point. You just need to start to more consistently think of, how do I start to ask these questions, and how do I start to consider the pelvic floor in my clinical practice? One of the things that I like to say is that really pelvic floor rehab is just orthopedics in a cave, okay? I strongly believe that pelvic floor rehab belongs in the orthopedic division, not in the women's health division, because I think all the men here have pelvic floors too, and children do, right? It's not a women's health problem, right? It's just a muscular problem that somehow we are not that comfortable with because it's in an area that we have to access vaginally or rectally, okay? So I really want you to start to think about, what are your own biases, right? What biases do you take to your patient's experience? And are you starting to affect the decisions that your patients are able to make because you're not giving them maybe the best choices that they can make those decisions on? So that's one piece I want to think about. I also put the mature hands, I love those mature hands, on the bottom right hand of the screen, because I want to also say to pelvic health therapists, and I do on a regular basis, that we need to use our hands maturely and wisely as well, that we do not need to pathologize the pelvic floor, that we need to recognize that it is part of a tension system, and that there are many ways to decrease top-down tension other than releasing trigger points and skin rolling and doing all kinds of manual therapy, okay? The other thing that I want to be really clear about for some people who may not recognize is that pelvic floor rehab, we have level 1 evidence. We have 2 Cochrane collaborations that actually support that internally palpating the pelvic floor and retraining strength that way has level 1 evidence. There's a ton of research now to support that that's what we need to be doing to strengthen the pelvic floor. It's not handing a woman a sheet and saying, squeeze those muscles as if stopping a midstream urine. Best of luck to you. Hope that goes well, right? That is not best evidence practice at this point, right? But there's a disconnect, right? There is a problem that we have here because right now, at least in clinical practice, it's left to specialty PTs, right? Specialist PTs who've done some ongoing training, but every one of your patients has a pelvic floor. And a high percentage of them are dysfunctional, whatever that means, right? They're tight, they're weak, they're not coordinated, they're not doing what they should be doing. And yet, you know, physicians aren't being trained. It's definitely not in their training program. Nurses aren't, midwives aren't. We certainly, from a fitness perspective, have a hard time knowing or understanding what's happening with our clients' pelvic floors in front of us. And so there's this large disconnect. The problem then becomes, we know before we start a new exercise program, we're told, you know, check with your doctor before starting an exercise program. All right, so I'm 6 weeks postpartum. I go to my doctor and I say, I'd like to start boot camp. Is that okay? Well, you're not bleeding anymore, so that's good. Go ahead. But no one's assessed the pelvic floor. Do you have adequate strength? Do you have good timing and coordination? Because if you don't, you're putting your patient at risk, right? And we're answering those questions for our patients as well. So there is a big disconnect here. The other disconnect happens in high-level athletes, and I'm not picking on CrossFit, and I know there's been a couple of different comments about CrossFit. I have a physician, one of my best friends is a physician, and he loves CrossFit because it's his social outlet. There's no question about it. I always have to rein him in a little bit, but you know, there was a video that went viral about 3 or 4 years ago on CrossFit, and a gynecologist on the video said, we all pee when we do double unders. Is that what they're called? Yeah, double unders? We all pee, that's normal. Well, no, you are overloading your system. That is not normal, and that is not the message that women should be getting, right? So we have this problem, and it's gonna take a lot of us to get on board to change it. Here's a discussion that I have had with the College of Physiotherapists of Ontario, because If you go back to your practice on Monday morning and you go to assess a knee that's just been injured, and you don't undress that knee and put your hands on that knee and assess it and do all your special tests, and you just kind of look at it through a pair of jeans and give them an exercise and send them away, they have every right. I don't know what the complaint system is like here in the US, but you have every right, your patient does, to go and complain to your college, and that's a valid complaint, right? We cannot treat a body part without assessing it. Why is that okay for the pelvic floor? Right? It is the only part of the body that we treat and we don't assess. It's not okay. So just think about that. So how do we change? How do we change our practice? Well, first of all, maybe it starts with a screening questionnaire. You have one in front of you. Essentially, the basis of that screening questionnaire is a bunch of conditions that are highly correlated with pelvic floor dysfunction and a bunch of questions that would be suggestive that you need to ask some more questions. Okay? It's a starting point, so maybe you start there. The next place that you have to go is you need to start taking a couple of classes around how do I ask questions around sexual function. If my patient tells me that they're having pain with orgasm, what does that mean? What do I do about it? And if you're not prepared to go there, then you shouldn't be asking the question, but then we really have to start saying, how do we treat these patients with low back pain, okay? This lady on the bottom right, we need to know more about different types of incontinence, right? Would you say the lady on the bottom right has stress incontinence? Put your hand up if you would guess that she has stress incontinence. How would you know? Just by the picture, right? She's actually got urge incontinence. She looks pretty stressed, doesn't she? But the difference between stress and urge incontinence, do you know what the difference is? And you need to if you're going to start to treat this. So one of the things that we can do is we can use the questionnaire to screen for pelvic floor dysfunction, and we can use some of the data that we've collected in this study and that we're publishing to start to look at if they're having pain with intercourse, if they're having very specific perineal, groin, genital, sort of lower abdominal pain, if they have a positive forced Faber, and if they have high levels of disability, those are signs that you're going to start to say, maybe this is an overactive pelvic floor. These are definitely women that I'm not going to start to train their pelvic floor or do core strengthening with. On the other hand, if they have stress incontinence, they've got pelvic organ prolapse, maybe lower levels of disability, you're starting to suggest that maybe training might be worth, training the pelvic floor might be the direction we want to go in. You can then specifically start to take a class that teaches a non-internal approach, right? So we have to not just ignore the pelvic floor. We can learn many external strategies. We can learn how to use a bladder diary, a fiber diary. We can use behavioral techniques. We can be objective in how to measure leakage using a 24-hour pad test, for example. There are many things that you can do as a non-internal therapist. The other piece that I really want you to think about, and we're talking about the pelvic floor, but if we go back to our anatomy, we need to think about the obturator internus, which is the inner walls of the pelvis where the pelvic floor suspends from, right? So I don't know if I have a light on here, right? So the obturator internus is here, and the pelvic floor actually suspends off the obturator internus through the arcus tendinus levator ani, the fascial tension, or the fascial line, the ligamentous line off of that side wall. So when we have problems in the obturator internus, we often see comorbid problems in the pelvic floor and vice versa. The other thing we need to recognize in OI problems and obturator internus problems is that it mimics many of the pain conditions that we assign to other structural problems in the low back and the pelvis. Okay? All of these different areas are pain areas that can actually be connected to tension in the obturator internus. Even just to start to think as a trainer or as an orthopedic therapist, when's the last time you actually gave someone pigeon or a stretch that brings their knee and their foot in at the same time into hip flexion to actually lengthen the obturator internus more specifically? Okay, so incorporating that into our practice. Okay, take-home messages. First of all, I think we all need to screen for pelvic floor dysfunction in all of our females presenting with lumbo-pelvic pain. There's a strong correlation. We need to develop skills to treat both states of pelvic floor dysfunction, both weakness and tightness. Weakness is not the default mode. Weakness should be treated with internal treatment. That is what we have level 1 evidence for at this point. And so if we're evidence-based practitioners, that is what we should be doing. However, if you treat non-internally, at least know when to refer to an internal therapist and start to connect with an internal therapist close by, so that when they don't make appropriate subjective and objective gains, that we can make that referral on. Thank you very much.
Just a little bit of time to take a couple of questions before our break. So if we've got a question right up front right away, and then we have another one in the back next. And another one over here third.
I'm asking this question on behalf of a client. How does one find a practitioner that you feel confident referring to? Because I'm 300 miles from Sandy Hilton. But I have a client with chronic pelvic pain.
Yeah.
She's gone the regular doctor route.
Yeah.
They told her she should go to a PT. She said, I'm afraid to go. And I haven't said this to her, but quite frankly, I think her fears are rational.
Right. So first of all, I need to recognize Sandy. You might want to answer that one. I'm going to answer. Sandy is here. She's in the back. And so I can't answer for how you find that in the U.S., but there are definitely ways. Like all other types of therapy, not all pelvic health therapy is created equal. And I think one of the things that, again, we need to just really be careful of in the pelvic floor is this is an area we primarily protect. And if treatment is fairly aggressive and creates pain, it can create more of a defense mechanism. Same sort of thing that Peter O'Sullivan was talking about in his pre-conference course, right? So we have to be careful. But Sandy, do you have a comment?
Yeah, I checked with Sarah because she's my business partner, and this would get me in trouble if I didn't. But get a hold of us, and we'll help find someone, because what you've heard all weekend is that it's that connection that really matters, and there are some not good matches, and that, especially in a vulnerable population, could go very wrong and give someone the false idea that they couldn't get better when it could just be not a good fit.
Next question.
Yeah, my question was the screening, the list of screens that you placed up there, Carolyn.
Yeah.
That also applies to men as well?
Yeah, so
Okay.
it's actually for both men and women.
Okay.
And the screening validation study that we're doing is being done on men and women in hip and low back pain. Okay? Yeah. Thanks.
Hi, I'm a massage therapist. So as an external therapist and dealing with male pelvic floor dysfunction, for example, I have a client he has an internal therapist, but I've gotten a lot more results with what I've been doing with him as opposed to what, she finally just tapered him off the treatments. So I guess my question is, like, we're working with TMJ and diaphragmatic breathing and this stuff. Yeah, so what can be done more as more of an external therapist? I don't know if I was wording that right. I mean, I'm working with, I always think of those as three planes, three transverse planes.
And pelvic pain is the issue.
He was sent to me for pudendal nerve, which
so
it sounded like
pelvic
people.
pain.
But once I started working with him, I was like, I don't think it is pudendal, And then I've gotten him really far along than he has in the last 10 years with anybody else.
Right.
But.
We have to be careful that, again, we don't over-pathologize the pelvic floor, and that can definitely be a problem as well, which is why I kind of put the wise woman with the wise hands on there. I mean, starting with the very basics of breathing and relaxation techniques and stress management techniques and teaching them to move again with less pain, finding movement patterns for them that are teach them and allow them to relax into movement, into positions, right? So it's that whole same concept. I don't know if you were at Professor O'Sullivan's class at all prior to the conference, but all the principles that we've been learning, really, this is a top-down problem that happens to be represented in the pelvic floor. And so all those great techniques you learn otherwise to down-regulate, look at their mood, look at their psychosocial scores, look at depression, anxiety, stress, all of those pieces. you have to figure out what the driver is for that, or multiple drivers usually for that particular patient.
Yeah, and in my head too, I thought that was
Yeah, so there's all of those pieces. It's not just one answer for sure.
We had just started to sort of address that in our session.
Yeah. So you can see that if the pelvic floor is really being protected, that treatment to the pelvic floor, if it's sensitized and sensitive, may just increase that level of sensitivity, which is maybe why he wasn't doing particularly well with the internal therapist, if that was the focus. Oh, oh. There's no self-efficacy there. That's a problem. Yeah.
So we have a question right over here in the middle. While the microphone's heading over there, are there any particular references that you would recommend for therapists that don't do internal work to start getting an idea of how to understand these things?
Yeah. I mean, you definitely want a good incontinence reference. I'm not even sure if I know a good incontinence reference at this point. Ladies, what would you direct there? I mean, from a pain reference, I would give them a headache in the pelvis still at this point. Would probably be the direction I might start with that. A Headache in the Pelvis by Anderson, David Anderson, and what's that? Why Pelvic Pain Hurts. Why Pelvic Pain Hurts would be a good book. If you really want to understand more about overactivity of the pelvic floor, there's a brand new textbook called The Overactive Pelvic Floor that was edited by Anna Padoa and Rosenbaum. Why can't I think of her first name right now? She'll kill me. Thank you, Tally. And so that's a great reference as well if you want to learn more about the overactive pelvic floor. Any of Carrie Bow's work would be a great place to start for incontinence and weakness.
Thank you.
Okay.
And we've got our last question over here.
Okay, I'm a massage therapist, and recently I've had just this incredible spate of new clients or existing clients who are suddenly apologizing for, I'm sorry I'm wearing my underwear, I know I don't normally do that, but I'm recently menopausal and I have this incontinence. And the doctor says that's just normal, and...
It's not normal.
Right. But would that be a pelvic floor dysfunction issue, or is there something else going on there?
Well, so nothing is just a simple sort of one problem often. So when it's a menopausal thing, then the hormonal change may have been the thing that tipped the problem over the edge. And so there may be a hormonal issue going on, but you can bet your bottom dollar that there's also a pelvic floor issue going on. And so when we look at the Cochrane collaboration, the level 1 evidence, what it says is that really doing internal exam and treatment for stress and urge urinary incontinence has about an 80 to 90% success rate, right? So that should be done before surgery is considered for sure. And so we need to start to use those guidelines because, you know, what other area of physiotherapy do we have that we have level 1 evidence in something that we do? It doesn't happen that much, right? Yeah. That helpful?
Yes, thank you.
Okay.
One last question. This is just for myself. Do we know if there are any pediatric pelvic floor specialists yet?
There are, and again, I can't tell you in the States how to get a hold of them, but certainly that is a subspecialty. There's a lot less internal work, if any internal work happening with pediatrics. There's lots that can be done with some EMG work and that sort of thing. So yes, there definitely are pediatric specialists, and some pelvic floor therapists will do all of it, and some will only do adults or men or women, but hopefully it's across the board. Okay.
Thank you very much.